My name is Melissa. I'm from the Hunter Cancer Research Alliance. So thanks for joining us this morning. Today's webinar is called Tips of the Trade, Conducting Implementation Research, a Case Study with Associate Professor Chris Paul, NHMRC Career Development Fellow with the School of Medicine and Public Health in the Priority Research Centre for Health Behaviour and the Hunter Medical Research Institute. This webinar is brought to you by the Cancer Implementation Science Community of Practice project as part of its education program around implementation science. The program features a series of events including workshops, seminars and webinars, and is supported by our resources website where you can subscribe to our newsletter. Find resources and register for the upcoming events online. There is a link on the holding page to get to the website if you haven't been there before. Before we start the presentation, we will just go through a little bit of housekeeping. So in addition to our online participants, we do have a live audience here in viewing the presentation with us today. So for everybody who is involved in the webinar, there will be time for a Q&A at the end of the presentation, but if you do have a question while Chris is presenting, there's two options. So for those at home, you can just type in your question using the question box where you can see the control panel on your monitor. So when you're writing out your question, please make sure that you click send to all so that all participants in the webinar will be able to view your question. We'll pass on these questions to Chris so that she can answer at an appropriate opportunity, and she is happy to take questions throughout the presentation in addition to the question time that we have at the end. For everybody here today, if you just want to give a little wave if you do have a question, either Chris and I will see that and at an appropriate time we'll break and you can answer your question. We don't have a microphone, so please try and use the big voice, but Chris is going to repeat the question if need be. And also following the webinar, there will be a survey that will appear on your computer screen, and also I think a link will be emailed to you. So we thank you in advance for your time in completing the survey. The feedback does help us to inform future webinars and supports the future education events that we're planning. So I'll now hand over the reins to our presenter, Associate Professor Chris Paul, to get us underway. So thanks, Chris, for taking the time to join us today.
Thanks, Mel, and thank you everyone for being here this morning, particularly after a long weekend and daylight saving. It's a big challenge, so thank you all for being here and welcome. I'd also like to acknowledge the traditional owners of the land on which we meet and acknowledge elders past and present. And as Mel mentioned, by all means, throw in your questions as we go so that you don't have to just listen to my voice the whole time. So the project I want to tell you a bit about today is P-SCIP for short. It's Pathways to Smoking Care Implementation Project. And I want to use this project as a bit of a story about some of the things that happen in the course of implementation and ways that you might deal with them. And hopefully there'll be people out there who can sympathise with some of the things that have happened. So if I can just get my mouse to behave, there we go. So rather than tell you all about the research that I do or have done, and I know a lot of you don't know who I am, that's just a little word cloud of the sorts of things I've done over the years. So you can get a sense there that things like smoking and cancer have been at the heart of the sorts of research I've been doing, but also a range of other bits and pieces over the years. So rather than bore you with that detail, you can just kind of absorb it, and hopefully that will mean something to you. All right, and also in order to understand where I'm coming from, it's helpful to know physically where I and some of my colleagues are located. So you can see there some pictures of the Newcastle coastline and city, even the beach where people occasionally park their tankers, a bit of the valley, and also some of the city revitalisation that's going on with new, more modern kind of buildings. So just to give you a flavour of one of the best places on earth to live and work. All right, so the P-SCIP project, what we're going to run through today is firstly the evidence base as to why implementation should be important in this particular setting, also some of the aims and methods of the study, a little bit of the data. I'm not going to focus too much on the data, but move on to really the story about how it did and didn't happen, and some challenges and solutions along the way, a few lessons learned, and then hopefully some questions at the end for which I might have an answer and I might not. Okay, so the team there, you can see there's quite a few people, and I particularly need to acknowledge Emma Sherwood, who began as a research assistant on the project and is now a PhD student. So she will be presenting a lot more of the data and extending and expanding on this project over the next couple of years. And thank you also to all of the team that have been an important part of this project as it's gone along. So, to the evidence for implementation. You might think that cessation of smoking once you've got a cancer diagnosis is a bit late. But in fact, cigarette smoking post-cancer diagnosis is associated with greater treatment toxicity and complications, greater medication side effects, an increased likelihood of hospitalisation, poorer performance status, so that's general health, quality of life type thing, greater morbidity, an increased likelihood of recurrence of cancer or a new primary cancer, and also a shorter length of life in the order of something like 6 to 18 months, with a lot of caveats around when that happens. For effective cessation, there's not a huge amount of literature compared to the broader field of smoking cessation about what works, what's an effective intervention. But we can say that it should include combination therapy, for example, nicotine patches plus counselling, so multiple forms of intervention, and also that it should start pre-treatment rather than wait, which is actually a big challenge for the field given that there's so much going on for patients around the time of diagnosis and treatment planning. However, despite all of that supporting evidence, smoking cessation care for cancer patients, we believe, is poor. The main data that we have is from the US, particularly produced by Graham Warren around how often cessation is raised and supported for cancer patients. But we've no reason to believe that that's different in Australia. What I'm going to use as my framework today is the theoretical domains framework and the Combe model that you probably would all be aware of by Susan, Mickey and colleagues, where we're looking at targeting a particular behaviour, designing intervention and delivering it, and we're going through those little boxes you can see towards the bottom around selecting the behaviour, understanding it, looking at what types of interventions are therefore needed because we now understand the behaviour a bit better, looking at behaviour change techniques and so forth. I'm going to focus more around the middle today, given that we're not quite through to the policy end of things just yet. And another bit of background, just for those of you who might not be familiar with the Combe model, you can see there at the heart of it, there's that concept that the person who is changing their behaviour, and in this case we're talking about the healthcare providers, not the patients, about changing the system to support patients. So it's about that provider's capability, opportunity and motivation. Then as you move out through different types of interventions and policy categories, that gives you the wider picture of how to enact capability, opportunity and motivation in that setting. And just a little bit more about the theoretical domains framework. I'll be running through or categorising things in terms of these dot points about knowledge, skills, social and professional role, beliefs about capabilities, optimism, and so forth. I won't mention every one every time, but that's just to give you a bit of a picture about how we'll organise the sorts of things we're talking about. So, on to the project itself. The aim of the research is to assist in achieving routine clinician delivery, and when I say clinicians here, I'm talking more broadly, so not just the medical doctors, but also nurses and allied health that are supporting that patient. So assisting those clinicians to routinely deliver smoking cessation care for cancer patients. And it's New South Wales focused as it's supported by Cancer Institute New South Wales. So the first three aims there are around the background, that we're trying to understand and specify the context of why smoking cessation support does or doesn't occur currently. So firstly, we were looking at the capacity of New South Wales hospitals to implement a system-wide approach, particularly for cancer patients, and then to look at the proportion of oncology, medical and nursing staff who routinely deliver cessation advice and support to their patients, and to look a bit at some of the patient and system factors that were associated with that delivery. And then moving on to more the translation story, which is specifically understanding the context in one setting and beginning to intervene. So the story is about pilot testing the feasibility of a smoking cessation implementation strategy, which was based on information drawn from those first 3 parts of the study. So there are the methods, and you can see the timeline in months along the bottom, and that's the planned timeline. And as we all know, things never go quite according to plan, but that's what we had, around 12 months to do 3 stages. The first stage is a key informant survey, and that involves particularly cancer services directors, cancer care coordinators, those kinds of people. And we had their contacts from the Cancer Institute's database. We tried to warm them up with some pre-contacting, did an online survey, some reminders, and we ended up with about half of the people that we had hoped to get there who completed that survey. In stage 2, we surveyed staff and patients from 7 hospitals, a mixture of metropolitan and non-metropolitan hospitals there. With the patient survey, the patients were surveyed during the oncology clinic. Some did the survey on iPad, some on paper with later data entry, and we have about 318 patients in that survey. That's actually ongoing as part of Emma's PhD work. But we had a good response rate from the patients there at 81%. For the staff survey, which is more where I'll focus today rather than the patient survey so much, eligible staff were those involved in oncology. They did a survey either on iPad there and then or via a link that was emailed to them. And we have 193 staff there with a much lower response rate of 32%, which, while not wonderful, is kind of what happens often in staff surveys. So bear that in mind as we're looking at a little bit of data. And then in stage 3, for the pilot intervention, we used that data from the first 2 stages. We did a bit of patient journey mapping and also looked at our data to devise an intervention. And there's also an evaluation of that pilot intervention, both qualitatively and quantitatively. I'm not going to talk about the evaluation data today, but more focus on the process and the barriers and encounters along the way. So then to look at some of the results, again, using the theoretical domains framework. First of all, I should mention that the one way of looking at the data is whether patients are receiving any of the 5 A's. So that's ask about their smoking status, are you a smoker, assess how much they're smoking, advise them to quit, assist them to quit, and then arrange whatever supports might be possible. And what you can see from that little spider diagram there is that based on our provider data, we asked them about both inpatients and outpatients, about whether they actually did those things, whether they asked people if they were smokers or not, whether they assessed and advised them to quit. And so this spider tells you the proportion of patients for whom providers reported each of those A's. And unfortunately, I couldn't get the spider to quite go out to 100%. So while it looks like for ask and assessing, providers are at 100% for inpatients, in fact, that's about 50%. So our providers answered separately for inpatients and outpatients. Hopefully you can see those little numbers there, that some providers were seeing both and some only one type of patient. But basically what that tells you is that while the most common things to do were to ask and assess, that happened about half the time for inpatients, but much less than half for outpatients. And that's important because a lot of cancer patients are outpatients. They're just attending for their chemotherapy or radiotherapy, for example, and so they're missing out on that part of the story. But then as far as being advised to quit, having assistance to quit and having something arranged for them, that's really not happening much for anybody. So that's the, I guess, confirmation that we're pretty similar to the US in terms of this not being a high priority for patients who are particularly outpatients in oncology. So from our key informant and staff surveys, again, we were looking at the general context across 7 hospitals for those theoretical domains. For knowledge and skills, about 20% said that they weren't aware of how to refer to quitline, which is a fairly important key cessation support to offer to people. 8% said they had received cessation training, and none of them reported that as being oncology specific. So we could see there that there's a bit of a gap around knowledge and skills that needs to be filled. In terms of their social or professional role and identity, up to a third thought that it was not their role to provide cessation support to their patients. But most of them, 97%, believed that it was appropriate to provide smoking cessation care to cancer patients. So they don't have a problem with the idea, but a lot of them don't see it as their role, or some of them don't see it as their role. In terms of beliefs about their capabilities, only 23% felt competent to advise on quitting strategies. So that starts to explain why they don't go further than asking and assessing. In terms of optimism and pessimism, beliefs about the consequences of their action, a small but sizable, I guess, minority think that their actions will not affect the patient's quit success. So there's a bit of nihilism there about whether they can actually do something that might help their patients to quit. In terms of emotion, one thing that we were concerned about is whether patients saw that as detrimental to the patient-provider relationship to ask about smoking, and only 10% thought that that was the case. In terms of reinforcement, 12% said that they'd received feedback about their smoking care practices, and 5% reported that there was some form of staff incentive if they were to provide that care, which is actually higher than I thought. I didn't think that anybody would be getting incentive. In terms of memory, which is particularly important in a very busy, highly pressured environment, 17% that said that they were aware of reminders or prompts to provide cessation care. And then looking at the environment and the context and resources that they believe are available to them, about half to 3/4 said that they have access to information about the patient's smoking status when they see them. But when more about what form that was in, that was rarely electronic. So it's not as though there's a seamless set of data that flows through the system electronically that carries smoking status in a way that nurses see that while they're interacting with the patient. None of them said that nicotine replacement therapy like patches or gum was available on site to oncology outpatients. It was available to inpatients, given that patients can't smoke while they're an inpatient, but for outpatients that wasn't there, which obviously makes it difficult to demonstrate or advise or give the patient something to take home and get started with. Only 5% said that they have an automated referral system for something like the quitline or some other cessation support. And obviously, automation makes things a whole lot easier. In terms of social influences, 17% said that they had some sort of explicit endorsement from management about this type of care, and 71% said that their team, so their particular team within oncology, never discussed the issue of smoking among their patients. So it's not a front of mind thing. So overall, what we're seeing here about the general context, including the data that I haven't presented, is that there's a generally positive view that we should help these patients to quit, both at their own personal level and a general peer level, but there's an absence of endorsement about training, resources, supports, and so forth. So in terms of what the implementation journey is, it's probably not a ride on the rapids where you're going to smash into the difficulties of people not wanting to do this, thinking it's a terrible idea to help patients to quit. It's probably more of a climbing of the mountains, a slow and steady kind of approach where there are plenty of challenges, but they're perhaps not going to come suddenly out of the blue in the form of opposition from a particular professional group. So I'll just stop now for a moment and just check whether there are any questions so far. And it looks like everyone's awake, which is a good thing at my end of things, but no burning questions. Were there any to you, Mel?
No, none.
Okay.
Yeah.
All right. Okay, we'll just carry on then and talk a little bit about some of the challenges and solutions in the single site where we piloted our intervention. Oh, there is one. Okay.
How do you decide what constructs to assess in the staff surveys?
So if everyone heard that question, it was about the constructs which how to decide which constructs to assess in the staff surveys. Things like the theoretical domains framework are helpful, but I think probably thrown in there in our case was just a little bit of local knowledge, what's been looked at in the past. So we did borrow from the Warren surveys that were done in the US, which weren't designed particularly along the lines of the theoretical domains framework, and we also drew on what was done more broadly in the cessation area of research, because that's a fairly mature area in other clinical groups and in the community around what's kind of best practice in terms of cessation support. But in trying to get the broad picture, I think probably that list of domains from the theoretical domains framework is the most helpful thing to do to get something quite comprehensive. Hopefully that answers the question. Please type in a further one if that's not quite getting at what you want. Okay, so no other questions popping up? Good, thanks. Okay, so hopefully that's what you needed to hear. All right, so again, following that kind of framework and coming from the perspective of trying to co-design interventions from the start with the people who are going to be using them, here's what happened. And I've tried to be a little bit warts and all, so hopefully you find that helpful. So there was a challenge around taking that general information and designing intervention when we got to the specific context. So what I'm about to put up is a flow diagram, and it's got lots of small text in it, so I'm not expecting that you read it, but just get a sense of when you look at it how complex the pathway is for patients, and therefore for someone trying to design an intervention that puts something consistent in there for patients so they don't slip through the cracks. So this is the medical oncology patient pathway. So you can see there's lots of points at which and lots of different providers that you need to be able to work with in order to make sure that patients receive a consistent routine kind of intervention. And it's also the case that at each of those points, almost invariably, they're quite brief interactions. So that's a challenge in itself to try and deal with that kind of setting. So that's medical oncology. We did the same thing in radiation oncology, and they have quite some similarities, but they are different. As you can see, there's a few different boxes from the left to the right-hand side of the screen. And so that meant that doing something simple and straightforward was not possible, but still we found ways to work with that system. And then where we ran into some particular challenges was the surgical patient pathway. We didn't actually manage to map it in any clarity, so it remained looking like that mess of highways and freeways. And so that was something that we didn't actually solve. So our pilot intervention focused on those outpatients in medical oncology and radiation oncology, and that meant that if you are a patient who's receiving only surgery, you didn't receive something that was consistent and made sure that you at least got some form of advice and support. So that's one part of the story which we haven't given up on, but I guess is part of the warts and all picture of how things happen. Now this slide is about then what did we do? What did we put in place as our solution? And those little coloured boxes you can see across the top are the key for the next diagram that I want to show you. And this is the cessation care model that we came up with to put in place for the medical oncology outpatients. So the patient in orange attends the centre, and then in green you can see what the nursing staff do. So that's about asking their status when they take vital signs, asking about smoking, I should say. And they put together a brightly coloured sheet and pack that goes to the medical oncologist. And then when the patient gets to the blue squares with the medical oncologist, they provide some advice and information. And one of the things you can see there in orange is that the patient ends up with a task to take their fax referral form for the quit line to the administration assistant who will send it off for them. So you can see there's a little bit for each person to do, and then on subsequent visits, again in the blue, the medical oncologist can include a referral to drug and alcohol services if that person hasn't found anything else helpful, and they complete some information in the electronic system. So that's what this particular department decided they were happy to do, so giving very much the basics and the tasks split amongst staff. And then what I'll put up next is radiation oncology. And please don't attempt to read all that tiny writing, but it's just for comparison. You can see that there's an extra colour in there. The radiation therapists take on a role because they're seeing patients regularly in just checking and supporting patients and perhaps helping them to, again, be referred to quitline or to drug and alcohol if they are interested in available. And you can see right down the bottom there's a red box for something called a typist, which some of the younger members of the audience might not have heard of. So it seems like an archaic thing to do, but it was a way to ensure that we had sufficient information going out to the GPs to support the patients should the patient then go back to their GP for cessation support. So we had slightly different models, but with the same set of principles about getting, being asked consistently, being advised, and then moving on to actually getting some form of assistance and arranging something for them, whether that be with their, with the quit line, with their GP, with the drug and alcohol counsellor. And over time, one of the positive things that happened was the move towards the drug and alcohol counsellor actually coming down to radiation oncology rather than the patients having to go there. So we did make some progress on that front over time. So now looking at knowledge and skills, you would have noticed from the earlier data, and particularly in this setting, we discovered more anecdotally as we dug a bit more into what people felt capable and confident with. The question of pharmacotherapy, so nicotine replacement therapy and the other medications came up as something that oncologists weren't very comfortable with in terms of what they could recommend and dosage and so forth while people were having treatment. So that's just a little bit of a look at the medications, and this seems to be misbehaving a little bit, but anyway, what we did in that circumstance was work together with the Everq people at Cancer Institute to draw together the evidence around interactions between cessation pharmacotherapies and oncology treatment, and there's a 2-page document that sits there in Everq that they can readily access, and a lot of oncologists do use Everq, so that was there in a place that they could easily access and that they were comfortable with. We also gave them a very practical table where they could quickly see which medications were okay with which types of treatment, and then the brightly coloured sheet that the nurse puts in with the package to go to the oncologist when they identify a patient as a smoker, that has a section at the bottom about pharmacotherapy, so it's an extra prompt right there in front of the doctor at the time that they're talking. So that seems to be working reasonably well. Now looking at the question of people's roles. Oh, we have a question.
So, Chris, do you anticipate the models of care being able to be implemented without change at any other sites, or will some adaptation be required? If so, what do you feel are the key parts of the models?
Okay, so I think the answer is yes, that things will be adapted. It seems that hospitals generally, from my experience, don't operate the same way everywhere, and certainly oncology departments don't operate the same way everywhere. So I think it's the case that you have to be prepared to adapt, definitely. Then in terms of whether, so I think the question was around what are the key parts of the model. So if we're talking about a smoking cessation model, then the key parts are about making sure the question is asked and people are then moving on to getting advice and assistance, and that being done in a way that makes it very easy for them. So those are the key parts of the care model, whereas the key parts of the implementation model, that's a slightly different question, and I think if that's really what the question's about, what are the key parts of the implementation model, I think that is probably dependent on the types of data that you gather in your in those first phases of understanding the behaviour. I would say that you will identify some general issues that seem to be consistent in that, say, 75% of people say, I don't know how to do X. Clearly that's something you need to focus on, that issue of knowledge and skills, whereas in other circumstances it won't be obvious exactly which part of the theoretical domains framework is the biggest issue. But certainly if people don't know how to do something, they're not going to do it. So is there any further on that question? No. Right, okay, but please bring it up again later if I'm not answering that sufficiently. All right, so on to social professional role, etc. Some of the words that I can print on the screen are things like it being inappropriate to ask people if they smoke and seeing it as being the GP's job. And you can see from those images on the right, not everyone is wildly positive. They have other things that are on their mind and perhaps don't see it as important. But certainly some staff very much have their eye on the ball and are interested and see this as important and want to know how to integrate it into their practice in a practical way. So you can see there's a bit of variety to deal with. And so how did we tackle that? I think we needed to be prepared to repeatedly provide the evidence base to continue to convince people that it wasn't just our idea of a nice thing to do, but to remind them of the clinical benefit, because that's clearly very important to them in caring for their patients. To also illustrate, which I didn't provide you the data about patients' interest, but to counter those thoughts that patients, if they were going to quit, they already did it when they got a diagnosis, and they're not that interested. It's their only pleasure in life, those kinds of things. We needed to use our patient data to really counter those thoughts and perspectives. We had to be very interested in finding practical, quick strategies to help people, given all the pressure that they're under, and also draw in team members that had credibility for them, who could endorse the importance of what we were trying to achieve, rather than it be seen as something externally visited on them. And as you can see from our friendly little Dory on the right, we needed to be endlessly positive and just keep on keeping on. And two of the people in the room here, Emma Sherwood and Paula Bridge, have been instrumental in making that happen. So you have to have the right people to be endlessly positive as well. All right, so as I mentioned earlier, having prompts and so forth are very important around this idea of memory and attention and decision making, and it's also kind of overlapping with that domain about the environment. We had at this single site some particular challenges around incompatible information systems and doctors telling us that they ignore various electronic icons and alerts because it's not important to them. So it's not enough just to have it there in the electronic system and think pieces of information weren't passing from one place to another, not just to do with our project, but the system itself didn't work terribly well. So what we had to do there was trial multiple electronic processes and tailor them for the particular part of the system, which is not ideal, not particularly streamlined. and sort of workarounds. So where the electronic system didn't really accommodate what we were trying to do, which was pass prompts along the chain as people passed through the system, and find ways to kind of plug the gaps and put band-aids on. We found that it was important to have nurse-driven actions because while the oncologists were much more about decision-making, the nurses were much more about making things happen. We ended up with both hard copy and electronic reminders, so that yellow sheet there was something that the nurses physically gave to the patient to take into the doctor. And we also had to stick with a fax system for getting people referred to the quit line. We did try very hard to get something electronic in place, and it's my understanding that the Cancer Institute is working on that issue more broadly, but it couldn't be put in place in this particular pilot. So what we ended up with was multiple ways to try and achieve something and make sure that patients didn't slip through the cracks. And I'm sure many of you would have had to do those kind of things before. Now, looking at beliefs about capabilities and consequences, there were concerns around the timing and sensitivity of broaching the issue of smoking, given that patients are particularly vulnerable when they're in that early phase of diagnosis and planning their treatment and making a lot of decisions. So what we did was a little project off to the side, which was developing some draft consensus guidelines, and in that process we involved both patients and providers and a broader group involved in communication skills to get some guidelines together around how to discuss smoking for this particular patient group, given that not much had been done with them around how they wanted to have this discussed. And so what we came up with was a set of principles, so that's just an extract from them, and then some very practical ways in which you could frame or phrase the sorts of things that, that needed to be said in a way that was both sensitive but also concise, so that oncologists and nurses didn't find themselves wasting time trying to figure out how to say what they needed to say. So those were some tools that we needed to make accessible for our providers so that they could feel capable and confident and not have negative consequences in those interactions as much as is humanly possible. And in terms of social influences, this was a particularly challenging one in that there are a number of disparate groups within the system who were still important to patients' experiences and felt that they had a stake and needed to be consulted. And they weren't always obvious. And given that there was such a number of them, the system has lots of different groups that feed in and work together. We had to be prepared to go back to that kind of mapping process and reconsider, engage in lots of apologetic communication, being very cordial and bringing people in late and finding ways to do that. So I guess I can't emphasize enough the importance of trying to do your scoping very thoroughly at the outset and not accepting perhaps second-hand views about whether a particular group needed to be involved or not, but going to them, getting their thoughts and feelings on the process so that there weren't any extra challenges along the way or bumps in the road that that meant that you couldn't proceed because someone was unhappy. So then our actual timeline versus our intended timeline. You can see at the bottom that the actual timeline was pretty much double what we had originally intended. That was partly because of some of those extra little side projects that we had to engage in along the way to make it work. But I think it's also the reality of implementation projects, particularly when you're dealing with a large organisation, which any hospital is, in perhaps very nimble environments, you might not find that things blow out to double, but I've been involved in enough projects now to know that our original 12-month time frame was very optimistic. Okay, So just in summary, in terms of those solutions, it is important to be very specific about the pathways and the behaviours and the challenges that will be there, both for the general context and for the very specific context that you're facing. And often with implementation research, we do need to go to multiple sites to do things like cluster RCTs. And being very clear about the general versus the specific is really important. We also need to understand and provide training and resources at a very detailed level that's tailored to the particular environment where it will be used, to be prepared to have multiple tools and workaround solutions when there's a lack of existing or smooth procedures. We need to use credible resources to deliver clinical messages, have repeated provision of the evidence with endless positivity, being a constant presence in the environment, and using multiple modes and types of prompts, thoroughly addressing practical issues, things like guidelines for communication that perhaps you hadn't expected, scanning for omitted groups and being continually inclusive, and repeated frequent interactions to provide feedback to people. I think I put a few things in my summary there that I took out of the main slide, so apologies if that doesn't quite add up. And a few additional keys to success, or at least avoidance of early failure, is having good relationships with clinical leaders, people who can act as champions and people who can act as allies in those environments. There's absolutely no substitute for that. Taking a co-design approach, so being always prepared to listen and to work together rather than saying this is the way it should be done. Having a very patient, polite, persistent approach with as much warmth as you can muster, even though it's sometimes frustrating, and allowing extended time to work with systems, given that there'll be unanticipated channels and sometimes hierarchical systems that you just have to wait for them to operate. And being very tolerant of coal-face circumstances. So by that I mean that generally people have goodwill towards these kinds of things, but they struggle with their own challenges within a very busy clinical environment, even something as simple as there's a lot of space pressure and they have to be out of that clinic by a certain time in order for the next one to move in. So we have to be prepared to work with that and be patient and oftentimes wait. So that's just a slide to remind you that there is an evaluation with results to come, which we're very excitedly looking forward to, but we don't quite have them all in yet. And that's it from me, and it's time for some more questions. So thank you everyone for listening.
So a question that's come through is, how do you explain the long timelines for implementation in grant applications?
That's a very good question, and I think one of the reasons that we had a 12-month timeline was that kind of suited the funding circumstances at the time, and so we often are a little bit optimistic in our grant applications. I think if you can give them a data-based explanation to say, we've done quite a bit of preparation and we know that it's going to take us at least 6 months to do this based on our experience with Project X or in our pilot work. So I think if you can give a solid explanation of why you need a long time frame, and perhaps if we put more of this kind of stuff into the literature, it might help us to be able to justify the need for time. I think that that's probably the way to go. So hopefully that answers your question. Are there any other questions? Yes.
Any in the room? Okay. Could you comment on the role of mixed methods in this research?
The role of mixed methods, I would say essential when you're trying to understand why something did or didn't work. So you absolutely need the quantitative of how much did it work, but oftentimes in implementation research you get a non-significant effect on something like a clinical outcome. And so if you are able to measure the kind of interim steps toward that outcome in both a quantitative way but also a qualitative way to understand what was really going on, I think mixed methods are absolutely essential, both in development but also understanding what happened and how it did or didn't work. So I'm a supporter of mixed methods. Any other questions? I think I've probably worn everybody out.
I'd just like to hear a bit more about some of the pragmatics and visits to the sites or meetings with clinicians, or how did that play out?
Okay, so the question, in case you didn't hear it, is about the pragmatics of the meetings at the site with clinicians and so forth. I would say that is a fairly drawn-out process. So we had a clinician involved in the project right from the start. So that meant that she could be, that's Fiona Day, could be a go-between, and also when Fiona left, James Lynham took over that role. And they were invaluable in helping us to find out what were the best points at which to arrange meetings, whether they were one-on-one things or whether they were going to particular meetings that they had regularly. So I guess that was kind of the starting point. And then as we sought to kind of map out the patient pathway and draw in more clinicians, again the broad term of clinicians, into the process, that helped us to identify where other kind of avenues might be, who other people were that needed to be involved. And generally, it was kind of like putting a jigsaw together or following the yellow brick road or whatever, that you'd have one meeting and find out a particular piece of information. They would tell you someone else that you needed to talk to get the other piece happening that this person couldn't do. So it was very much a kind of step-by-step unfolding kind of thing, that you couldn't tell right at the start who were all the people you needed to involve and how to involve them and when to talk to them. So perhaps if you worked with the same group in the same site frequently over a number of years, you would get that down pat. But that's generally not the case with implementation research, that you're going to new places at least some of the time. So I guess there isn't an ideal way to do that other than to ask a lot of questions about who else do I need to talk to, what's the best way to get in contact with them, as long as you've got that very first inroad of someone in the system. And we were very lucky too that there were quite a few people who were very supportive, and so that helped to kind of smooth the way into various other meetings and interactions. So the next question is, how did you decide on using the TDF and COMB frameworks? I have found, like initially when the COMB framework came out, I found it easy to remember. So you've just got your COMB to remember, and then the intervention functions and policy frameworks around that as being a fairly neat kind of approach. And then I guess Susan McKee and her colleagues have been very thorough around then how do you understand behaviours. So they tend to have a very thorough approach to developing those kinds of tools. So I guess really for me, it was personal preference, one that I was comfortable working with. Of course, there are other frameworks that you can use, but I find them to be fairly well respected as well. And the next question is, how much support did the P-SCIP team provide to the site during implementation? So, correct me if you disagree, Emma, but I would say a lot of support to put things in place, so to get the prompts into the electronic system, to get the pieces of paper and get people doing things. That set up a lot of support, but then once they've begun, we're pretty much hands-off in terms of changing what they're doing, other than we do attend regularly to get feedback so that we can adjust and refine things. So, for example, discovering that we needed to put a little extra box in one of the fields that they need to fill in about what kind of care they've provided. So we're in the process of changing that, and we'll let them know when it's up and running with that extra bit of information that they wanted. So hopefully that answers the question. But is there anything that you would add, Emma, from your many, many trips to the hospital?
Maybe it's just like face-to-face meetings as well. Like we devoted a lot of time to doing that, so maybe having someone available to do that on your investigative team is important.
Yeah. So just in case you didn't hear that, Emma's point was about making sure someone on your team has the time to be able to attend meetings face-to-face, and perhaps to add to that, at short notice, whenever they're free. Okay, any other questions? Thank you again, everyone, for participating today. Thank you.